I'm Frances Zapala. I'm a pediatric cardiologist at the Nemours Cardiac Center, DuPont Hospital for Children in Wilmington, Delaware. And today I'm going to talk to you about why we need to be testing our children for cholesterol. And one of the main reasons is we want to find those children with the genetic form of high cholesterol or familial hypercholesterolemia. It's actually one of the most common genetic mutations, more common than a lot of the other genetic diseases that we test children for routinely. We used to think that 1 in 500 people had the genetic form or the heterozygous form of familial hypercholesterolemia. Newer studies are now showing that it's closer to 1 in 200 to 250 who have familial hypercholesterolemia. And the homozygous, the more rarer form, we used to think was 1 in a million. It's probably closer to 1 in 600,000. It's actually a lot more common in certain populations, especially French Canadians, Ashkenazi Jews, the Lebanese, and South African Afrikaners. Those populations have been found to have a frequency of 1 in every 67 people. The other reason that's really important is that if left untreated, these patients are 20 times more likely to develop aggressive early heart disease. A man with familial hypercholesterolemia has a 50% chance of having a heart attack before the age of 50. A woman with familial hypercholesterolemia has a 30% risk of having a heart attack before the age of 60. Unfortunately, 90% of patients with familial hypercholesterolemia go undiagnosed and untreated until they have their first heart attack or stroke. With treatment, these patients can have a normal lifespan. The homozygotes are even more aggressive. This process begins before birth and progresses rapidly. These children can have their first heart attack as a teenager or in their early 20s. We've also found that family history alone is not enough. A lot of parents don't know they have familial hypercholesterolemia. They may not know their parents' history or their grandparents' history. This study in London, where they screened over 10,000 children for high cholesterol and the genetic mutation for familial hypercholesterolemia, found that for every 1,000 children they screened, they identified not only 4 children with familial hypercholesterolemia, but 4 parents who didn't know that they had familial hypercholesterolemia. These are some of the faces of patients with familial hypercholesterolemia. All young, appearingly healthy people who had their first bypass surgery at the age of 28, had a heart attack at 29, who had at the age of 2 an LDL cholesterol of 957. So this is one of the reasons why we want to start testing children, to find these children early and start treating them to prevent them from ever having their first heart attack or stroke at all, and definitely in their 20s and 30s. When we look at some of the countries that are screening for familial hypercholesterolemia, the Netherlands have done an excellent job. 71% of the population have been screened and diagnosed. When you look at the United States, less than 1% of the population have been screened and identified. Cost savings, this is another reason why we should be testing and looking for patients. In the UK, they found that they saved almost $4 million from care of coronary artery disease by identifying patients early and treating them appropriately. Similar findings were found in Spain with screening and prevention of coronary artery disease. Here's an example of how early treatment can really be beneficial. The blue line are the patients who are identified and are treated with a statin, and their incidence of living free of any disease is very good over 12 years. As opposed to those in the red dotted line, these are the patients who have familial hypercholesterolemia but weren't identified and treated. And you can see that their incidence of disease over 12 years is dramatically different than those who are treated. Here's a slide demonstrating the benefits of early treatment. This gray line are the patients with homozygous familial hypercholesterolemia, and you see if they're not treated and identified early, they reach the threshold for coronary artery disease by 12 and a half years of age. When we identify the heterozygotes early, so here in the red line is a heterozygote, when we start treating them with low-dose statin early, we can see that their rate of disease is dramatically decreased compared to those who don't receive statin treatments and reach the threshold for coronary artery disease by the age of 35. Those treated early, that disease can be delayed for almost 20 years. And the green dotted line are those siblings who don't have familial hypercholesterolemia, and you can see that their risk for heart disease is dramatically less. This is a case that was presented in the European Heart Journal article that really summarizes why we want to test children for cholesterol so we can identify those children early and treat them. On his 10th birthday, a boy whose father died exactly 1 year ago at the age of 30 comes to consult you with his mother. The mother is worried that her son will have the same fate because the son also has high cholesterol. What is your approach in this case? Well, in this case, the boy, when he was 11, received genetic testing and was found to have the genetic mutation for familial hypercholesterolemia, and he was started on lifestyle management, healthy diet, and exercise. Statins were initiated around his 12th birthday. Now, after nearly 20 years, this young man is now achieving all of his treatment goals, and he is older than his father was at the time of the father's death. Also, as a result, 33 of this man's relatives took advantage of the genetic screening. 14 were found to have high cholesterol as well and were treated appropriately. This family scenario highlights the value of cascade screening and testing our children. By identifying these children early and treating them appropriately, we can prevent them from having early heart disease and early death had they gone untreated. Thank you again for your attention. I hope you enjoy the presentation.